Good morning. So I'll have two sessions today. First, I'll be discussing on OCT changes in neuro-ophthalmology, followed by emergencies in neuro-ophthalmology. So OCT changes in neuro-ophthalmology, I'll be discussing and following headings. These all parameters will be coming into shortly. The peripapillary retinal nerve fiber layer shows thickening in disc swelling, followed by quadratic thinning in the setting of optic atrophy. Here you can see the normal peripapillary retinal nerve fiber layer falling within the green area graph, whereas below you can see a case with a bilateral disc edema, papilledema showing thickening. That is the line is going above the green area. That is peripapillary thickening. But peripapillary thickness does not correlate with the visual acuity or the visual fields. That will be coming into shortly. Macular ganglion cell layer thickness, thinning is often the first sign of afferent visual pathway damage, and unlike RNFL thickness, it correlates with the visual acuity and visual fields. Then we can have small microcystic changes, that is microcystic macular edema in the inner nuclear layer in axonal degeneration, but these are non-specific changes. Another parameter is the optic nerve head volume, and this volume has more correlation with the Frison's grade of papilledema, and a cutoff of 3.97 millimeter cube is taken. And here this figure depicts increasing optic nerve head volume with increasing grades of papilledema. Another parameter that we can look into is the peripapillary retinal pigment epithelium Bruch's membrane angulation at the optic nerve head opening. And in the normal case, it is directed away from the vitreous in the form of a V shape, whereas in this swelling, you can see that it is angled forwards into the vitreous cavity in the form of an inverted U shape. And with the resolution of disc edema, it will come back to the normal V shape pattern. Optical coherence tomography angiography is useful in assessing the peripapillary radial capillary network that is not visualized on fluorescein angiography. And here you can see OCTA in a case of anterior ischemic optic neuropathy of the right eye, where you can see the flow voids in the temporal part of the optic disc and the disc swelling on the OCT B scan and normal left eye vasculature. Another thing is enhanced depth imaging OCT and SWEPSOS OCT. These help us to image the deeper layers of the optic nerve head, such as buried disc drusen. Now coming to clinical applications. Here, B-scan ultrasonography helps to pick up calcified drusen in the form of hyperechoic area at the optic nerve head like this, but it cannot pick up non-calcified ones. In such cases, we can go for the EDI OCT, which demonstrates these drusen lesions as a hyporeflective core lesions with a hyperreflective margin. And sometimes in swollen disc, you can also come across peripapillary hyperreflective ovoid mass-like structures like these, the so-called POMs, which is generally peripapillary axonal distensions. It's a non-specific and can be seen in any case of disc swelling, including papilledema. And optic disc drusen in fundus autofluorescence appear as bright specks. The superficial drusen appear as bright specks on the fundus autofluorescence image. In papilledema, other than this RNFL thickness and ONH volume, OCT also is helpful in demonstrating macular fluid, that is subretinal macular fluid or choroidal folds, as a cause for defective vision, because these are generally reversible. And this GCL thickness can also distinguish papilledema from pseudopapilledema. As you can see here in papilledema, here you can see the temporal aspect GCL thinning, whereas in pseudopapilledema it is uniform thickness all around. This is a case, a young female 33-year-old diagnosed with IIH and papilledema, and she had initial disc swelling with a progressive thinning of RNFL over time. However, you can see that there is with the treatment, there is an expansion of the visual speeds. In spite of the gross thinning of the RNFL, the fields are getting better. That is why it's not correlating with the visual fields. In optic neuritis, there is in the acute stage, there is elevation, that is increase in the RNFL thickness, and followed by temporal RNFL thinning around 2 to 3 months later. However, there is an OCT floor effect And the general mean thickness of does not fall below 30 micrometer in spite of severe optic atrophy. Macular ganglion cell layer is more sensitive and reliable index of acute neuroaxonal injury and shows changes early, even about 2 weeks after the onset. This microcystic macular edema can be observed, and in multiple sclerosis, it indicates disease activity and worse disability. Neuromyelitis optica causes increased thinning of RNFL and GCL compared to multiple sclerosis, and this more predominant in the inferior and the superior quadrants than the temporal quadrant. Here we can see a 26-year-old female with a defective vision, gross defective vision in the left eye due to emoji positive optic neuritis with a gross depression of the fields. You can see here this pallor of the disc. And she improved with IVMP, plasma pheresis, and immunosuppressives. This is case of a male patient with demyelinating old optic neuritis with optic atrophy in the right eye, showing diffuse thinning of the RNFL and grossly depressed fields as well as GCL thinning. In ischemic optic neuropathy, initially there is increased RNFL thickness and subsequent thinning within about 2 months. And the GCL shows thinning much earlier, even as early as 2 to 3 days after onset of symptoms. And the pattern of GCL involvement, such as this altitudinal pattern of loss in the superior aspects, goes more in favor of ischemic optic neuropathy, whereas a more generalized thinning all around is more in favor of optic neuritis. And in compressive optic neuropathy, OCT helps in diagnosis and monitoring compression as well as predicting the visual outcomes after decompression surgery. And the greater the RNFL and GCL thinning, the more poorer is the visual outcome. Here is a 6-year-old boy who who's diagnosed a case of opticochiasmatic glioma with a right eye optic atrophy and a pale disc, and the left eye with a initial disc edema. With a vision of 6/6 N6, but however a dense temporal field defect. And there is even though there is a atrophy, thinning of the RNFL over time, there is a gradual improvement, a mild improvement in the field following chemotherapy. Coming to toxic hereditary and nutritional optic neuropathies, here also in the early stages, there will be optic disc thickening and RNFL, there can be disc edema and thickening, whereas in the later stages, there is development of temporal thinning and temporal pallor. In glaucoma, OCT helps in diagnosing the thinning is more, because of the arcuate defects and inferior poles rather than temporal aspect. Whereas in vigabatrin, the thinning is occurring in the nasal, superior and inferior poles rather than the temporal aspect in other neuropathies. And OCT angiography helps to demonstrate reduced capillary perfusion around the optic nerve in demyelinating optic neuritis as well as in ischemic and Leber's and hereditary cases. Here is a case of OCTA in ischemic optic neuropathy, where you can see the right eye, it's acute disc edema, left eye or previous episode optic atrophy, the right eye showing OCTA showing the supratemporal aspect flow void, whereas in the disc in the left eye, peripapillary capillaries are uniformly decreased. So in conclusion, OCT imaging has revolutionized the diagnosis, monitoring and prognostication of neuro-ophthalmic conditions. However, the images has to be critically interpreted, keeping in mind the imaging artifacts that comes into play. Thank you.
Excellent presentation, Dr. Sreelekha. Very good documentation, and the pictures are also very clear, and you had an array of cases. Nice presentation. And to add a few, nowadays OCT is also useful in diagnosing Alzheimer's and Parkinson's disease also, and it is used by neurologists as well. Thank you.
Thank you.